Our third and final lecture on mental health issues in older people will focus on depression. We will look at the epidemiology of depression in older people, its clinical presentation, and diagnosis, particularly screening tools that can be used in the emergency setting. Depression is common in older people. These are some studies from France and the States which suggest that the incidence of depression in the emergency department in older patients ranges from anywhere between 15% and 58%. However, our ability as emergency physicians and nurses to detect depression is low. One study by Melton in 1997 showed that none of the patients who were found by the research team to be depressed were identified in the emergency department. And another study by Klummer in 1999 showed that less than 50% of patients diagnosed with depression were referred for further treatment. Part of the reason for this is that depression does not present typically in older patients. Patients often present with physical symptoms such as back pains, headaches, lethargy or weakness, and this is partly because older people find it difficult to talk about mental health issues. In addition, depression in the older age group can mimic psychiatric illness, so it can be confused with dementia, catatonia, or psychosis, because in older people with depression, they may experience delusions or hallucinations. Depression may also present with social problems like the inability to cope, increased use of services, or self-neglect. Pause the video for a second and see if you can think about some of the risk factors that increase the chances of depression in older people. As you may expect, there are many risk factors that increase the risk of depression in older people, including physical medical problems and psychosocial issues. Alcohol and drug abuse is seen in older people and will increase the risk of depression in this age group. Similarly, polypharmacy and drug use can increase the risk of depression in older people. There are some drugs that are particularly associated with depression in older people. These include sedative hypnotics, anticholinergic drugs such as antihistamines, antiemetics, and antipsychotics, and some specific drugs that older people may be on, such as beta blockers and alpha-methyl-dopa. Patients, older people with other chronic mental health issues, are at an increased risk of depression, as are older patients who lack family support. Financial issues often worsen depression in older people. Older people tend to feel vulnerable, and if on top of this there are real financial issues, it can be overwhelming and create depression or exacerbate depression in older people. Older people who have limited mobility or poor functional capacity are also at an increased risk of depression, as are older people with chronic illnesses. We'll discuss this in more detail a little later. So let's look at these comorbidities. Firstly, it's important to say that any comorbidity in an older person increases the risk of depression. However, this is particularly so in chronic life-limiting diseases such as poorly controlled diabetes mellitus, chronic heart failure, or chronic painful and chronic neurological conditions. Polypharmacy is definitely associated with an increased risk of depression, and certain medications are more implicated than others. These would include beta blockers, calcium antagonists, digoxin, alpha-methyl dopa, anticholinergics, and sedative hypnotics, as mentioned earlier. Depression is often missed in the emergency department, and therefore we need to have a robust approach to the diagnosis of depression. Many people have tried to create screening tools for depression in the emergency department. These need to be concise, easy to administer, sufficiently sensitive, and specific. So I'll just talk you through two of these. The first is the Mini Geriatric Depression Scale, which is a 15-point screening tool. And these are the questions that are asked. They do tend to cover a broad range of issues, including the patient's mood as well as their life and life activities. There are actually much more brief screening tools available as well, such as the 3-part screening tool developed by Fabaca in 2002. Just 3 questions, but with a high sensitivity, but a fairly low specificity, which means that we'll pick up all the depression patients, but most of the patients who screen positive, when further assessed, will be found not to have depression. So this was a very brief talk on depression in older people. If you have any questions, as usual, you can post them on the WhatsApp group or the TTEMA website chat. In summary, depression in older people is common. Presenting features can be atypical and obscure. Emergency physicians are not well trained to diagnose depression, and screening tools can be potentially effective and usable in the emergency department. This brings us to the end of our 3-part series on mental health issues in older people. I hope you enjoyed this and learned something from it. Thank you.